So the problem I'm trying to research is that Medicaid underpays doctors. And when Medicaid underpays doctors, it's hard for patients who have Medicaid insurance to find the doctors they need, to get the care they need. Either the providers that typically give care to low-income patients are, struggling with their finances, or they go out to doctors in the community, and a lot of them don't want to see the patients where they don't get paid a lot of money. So as part of the Affordable Care Act, they decided to pay Medicaid doctors more. They paid them the same amount that they pay Medicaid patients. That doubled the amount they got paid for those doctors that saw patients for primary care. So the question is that we are studying is, are there more doctors willing to see these Medicaid patients when they're paid twice as much as they were before? And as an economist, it seems like a pretty obvious answer to that question, that you get paid more, you're more likely to see patients. But this was a critical policy question, because this was a policy that was put in place for just 2 years, just to see how well it worked. And the hope was that doctors would engage the system at a time where Medicaid was expanding, there were more patients available. So what we did was we called up these practices, we had field workers who pretended they were patients. And they said, can I get a new patient appointment? And then we just marked down whether they got an appointment or not. It was as simple as that. Half the time, those scripts included patients who had Medicaid insurance, and half the time for a control group, they had private insurance. And we did this exact same study in 2012, before this policy went into effect. And then again this past spring in 2014, right in the middle of this implementation of this policy. And we saw about an 8 percentage point jump in the percentage of patients who were getting appointments. And what was really compelling about our findings was there's great variation between states in terms of how much pay increase, because Medicaid pays different amounts. It's a state-run program. And so for some states, the jump was double, 100% jump, and others maybe 30 or 40%. And in those states where the jump was double, the increase in appointment rates were about 15%. And in those states where it was much lower, it was about 5%. So you saw this much greater increase when they got paid even more. And then when we looked in the private insurance group as a control to say, maybe there's something else going on during the same time, we saw no change at all. So with some pretty compelling results, it really suggested that this policy worked to increase appointment availability for primary care physicians when you pay them more money in the Medicaid system. Well, this is a very timely research for policymakers. It was a 2-year policy that ended January 2015. So policymakers were really interested in whether this policy worked. So the key takeaway is the policy worked. And another key takeaway is that there's a debate about why doctors don't see Medicaid patients. And what this suggests is that if you pay them reasonably, they show up to see these patients, that it's really about payment. And it's not the fact that there may not be enough providers. I mean, there's some areas where there may not be enough providers overall, but the solution, if physicians aren't seeing Medicaid patients, is to pay them adequately. Our results seem to show it makes a difference. When we started this study, there was a lot of hesitation because it was the very beginning of this policy implementation. As I said, it was a 2-year policy. It was starting up in 2013, and that was when we were getting ready for our second round of data collection. Implementation was delayed by 6 months. They had real trouble figuring out exactly how to pass through payments if there's capitated managed care. It's a lot easier when it's a fee for service than when it's capitated. So there's struggles with implementation, and a lot of people said, well, the payment is temporary, and so doctors aren't going to change their patterns for a temporary policy. And the other thing that we had heard is that a lot of physicians weren't really calling up the Medicaid office and saying, gee, I really want to be in this program. So a lot of the anecdotal evidence was pointing towards there really being no action. So at the end of the summer, I think it was like September, we took our first peek at the results. And we were all very surprised to see such a large, unambiguous effect. So really the surprise was that we found something, particularly when the rhetoric at the time was that this policy really wasn't having an impact. Well, I think the most practical implication, I guess I think about it for policymakers. A lot of discussion at the state level. States were trying to decide if they wanted to, extend this pay bump policy. And what they were saying at the time was, there's no evidence yet. So we're not going to make a decision because there's no evidence. But now we have evidence, so I think the real practical implication for people who are kind of on the front lines of deciding whether doctors should be paid more for this specific policy is that there's evidence, and evidence-based policy is an important way to make policy, and here this policy seems to work. But I think there's a broader point that can be made that's important for physicians who run businesses, and I think physicians are not immune to the same economic incentives as anyone else running a business. I think that there's, when you're talking about health, there might be some, maybe moral obligation to see everyone who comes in your office, but you can't have an office that can turn the light on unless you can pay the bills. And when you don't pay enough to turn the lights on to see the patients who, the reimbursement is like $30 or $40 for a half hour of your time, it's really hard for some of these doctors to justify that in their day. They're just trying to, have a business where they bring in more money than they spend. So I think what this suggests is, from a practical end, particularly as someone who's running a business, is that physicians are running businesses too, and they shouldn't be set up against different rules than other businesses. There's a lot of debate in Congress right now. I wouldn't say a lot of debate in Congress, but this policy of this, what we call the Medicaid rate bump, was introduced in the president's budget just a couple weeks ago in February. He proposed to Congress that they extend the pay bump for another 2 years and make some modifications. And there's a lot that's going on in Washington to make some decisions about various aspects of health policy. It's all very, very political, but from a practical end, this is about a $6 billion a year policy to pay Medicaid providers for primary care at the same rate as they pay for Medicaid doctors the same amount as Medicare, and it costs $6 billion, which is really a drop in the bucket when you think of the $1 trillion Medicaid, ACA bill. And so I think the practical implications is, we know that there are some effects, important effects for patients, getting access to providers, having continuity of care, and this provides some evidence that that there's a benefit of this policy, and that now the politicians have to decide if that payment, that expense is worth it for the gain that you get. The focus here was on primary care physicians in Medicaid. That's what the policy was aimed at. But in Medicaid, it's really difficult, not only in some areas, not only to get access to primary care providers, but if you have a need for specialty care, it could be even more difficult. The payment gaps for specialty care can be even more severe. So the implications extend beyond primary care. You pay doctors more. They're more likely to extend appointment availability to patients with that insurance type, and I think it would extend beyond primary care providers to specialty care providers, and in particular areas where that access is a real issue, it suggests that paying specialty providers more money would help address that problem. There was a front page article in the Times right in December when this 2-year policy ended. It was always a temporary policy, and so payment rates doubled 2 years ago. But when they went back down in January 1st, the headline was, "Doctors get pay cuts of 50%. Will they still see patients?" So, I mean, at that time, it was a 50% reduction in the amount they were getting paid within Medicaid, but that was certainly a headline at the time. So I think I believe, what goes up is probably going to come down. So in response to the headline, what will happen now that payment rates have gone back down? I think we can expect that the gains that we saw in the last 2 years in terms of more doctors participating in Medicaid will probably go back down. And we'll go back in the field and measure it, but I think for the impact on Medicaid patients, I think it's an important finding. There's a perception that there are fewer doctors that see Medicaid patients. Maybe it's because doctors don't want to see Medicaid patients. And what this research suggests is that if you pay them reasonably, they'll show up to see these patients. And it's more about the payment rates than it is about something about this patient population. This is the first time we've been able to look at the relationship between payment rates and physician appointment availability, or just access, participation in the Medicaid program using experimental methods. So other people have looked in data. Those states that have higher payment rates tend to have more doctors that participate versus low, but it could be for a number of reasons that doctors set up that Medicaid sets up payment rates that way, and it's just observational. But to be able to go into the field, pose as patients actually seeking appointments, measure real behavior in kind of this audit methodology in this experimental way where we randomize the scripts to having Medicaid or private insurance we've controlled for other aspects of access really sets us apart. Really clean design that has this compelling narrative that you actually are measuring it by calling up doctors' offices. I think just that audit methodology is very compelling for people on the street. If you say I ran a regression analysis and my p-value was whatever, somehow you've already lost half the crowd. So it was both a clean experimental design, I think very compelling, easily to relate to finding. This paper that I was telling you about is part of a much larger project, larger data collection effort, which is about tracking how available physicians are for seeing patients around the insurance expansions of the Affordable Care Act. So in the past couple of years, it's been a large a group of people, 10, 15 million, who didn't have insurance before and now have insurance and will be demanding to see doctors in ways that they haven't before because they have insurance to cover those visits. So the fear is that that there won't be enough doctors to meet this increased demand for care. So we did our baseline measures in 2012 before insurance expanded. And in a number of different domains, we're studying whether there's sufficient capacity in the physician workforce to meet this increased demand. Are we going to see a squeeze on the Medicaid side? For private insurance, one of the questions that people are curious about is whether those people have always had insurance. The question is, will their care remain the same? But if their doctors are so busy because there are more patients, maybe for them, even their care won't be the same. And we'll be able to measure that. We'll have, these baseline data to know that what things were like before, and we can monitor changes. We're going to look at changes, look at the access issues that exist in health insurance exchanges. So there's a lot of questions we're still pursuing with this larger ongoing work. We're hoping to go back in the field to collect a third round of data within the next 6 to 12 months.